with Foxy, like we celebrated Mother's Day from the gynecological front. So this had huge gathering. And then there are few webinars where we had attendance close to 50, 100 also. So I think you, Abhi, as I said, you really can't predict. It's just
Yeah,
that if
I'm
people
not.
are,
Yeah. My question is, what sort of cautions and what sort of precaution we should be taking?
I mean, we had a, I mean, हाँ
give you 10 seconds.
Second last.
Good evening, all. I, Shreya from Torrent Pharma, welcome you all to the Spine series. a noble endeavor by team of Stavya spine surgeons. Thank you all for taking out time from your hectic schedules and joining us live today. Before we begin today, let me take you through the legend of Stavya. Stavya literally means Lord Krishna, the first spine doctor in the world. He treated Kubja, a hunchbacked woman from Mathura. The legend says that Kubja was a hunchbacked woman who once crossed paths in Mathura with Krishna. She offered him some sandalwood paste. Overwhelmed with her devotion, Krishna pressed his foot on her toes and lifted her chin with two fingers. It is said that Kubja stood straight. The name Stavya has henceforth continued. With similar passion, Stavya stands today helping thousands of patients lead a better life. The Spine series is an educational effort in the same direction. Aging is inevitable. Sedentary lifestyle, improper diet, improper postures further add challenges like obesity and muscle weakness. This eventually takes a toll on our spine health and can lead to multiple complications. As the challenges arise, so do the new possibilities. And today, to understand the same, we have an expert panel with us who shall be sharing their wealth of experience. But before we begin the program, let us all welcome our esteemed moderator and speakers for the day. Our esteemed moderator for the day is Dr. Bharat Dave, a spine surgeon with more than 30 years of experience. Dr. Dave has been an eminent speaker at all national and international platforms. He has also been a reviewer for many reputed journals like the Journal of Orthopedic Trauma, the Indian Spine Journal, the Asian Spine Journal, and the Global Spine Journal. A warm welcome to you, Dr. Dave. I now hand over the session to you. Thank you.
Thank you, Shreya. Thank you very much for the short, sweet introduction of this Stavya and introduction of mine as well. I have in my team 4 spine surgeons. So we 5 spine surgeons work together, and we plan to conduct this webinar over the 3 months. So we will be having total 6 webinars. The purpose of this webinar is to give education to many of us who are unaware of the natural history and conditions which really do need a lot of attention. I would like to introduce my first colleague, Dr. Ajay Krishnan. He is with us at Stavya since last 15 years, and he is specialized in deformity and endoscopic work. Another colleague of mine called Devanand, he is specialized in oncospine, and he is working at Stavya since last 5 years. Dr. Shivanand is working since last 2 years, and we plan him to sort of go ahead with the minimally invasive spine surgery. Devanand, Shivanand, and Ajay have been the fellow at the Stavya Hospital as well, and they have joined the parent institute. So that's been an honor for us. Dr. Ravi, he joined 1 year ago, and he is planning to get specialized in the anterior surgeries. So at the end, we probably at Stavya plan to excel our own team in order to do this subspecialty work. So what are we going to talk about in this webinar? Why spine gets affected? What are the conservative treatment measures for the lumbar prolapse disc and non-surgical intervention? And we are going to talk about the facts, myths, and some of the red flags as well. I think in the coming webinars, I really welcome you all along with your colleagues, orthopedic surgeons who may be having busy clinics or who may be having their own family issues with these spine problems. And I'm sure nobody is going to be without it. We all are going to age tomorrow, and we will have spine problems today or tomorrow, or with our family, or with our neighbors and relatives. I think those physiotherapists who run the clinics, particularly for the spine, they should really attend this, and those GPs also should attend, because they will be handling day-to-day activities for the into their clinical practice. So I urge you all to join in the next webinar, which will be on the first and third of the Thursday between 7 to 8 p.m. And I request you all to put the questions as well in the question and answer session. At the end, we will answer all your questions. We already have few, and today we will start with those few questions as well.
Good evening to everyone. Today's talk, being the first among the series of webinars, we'll start with the basics. We know most of our colleagues would be well versed with the basics of spine. So this talk would be like a refreshing of the knowledge as well as discussing some interesting facts about spine. They say that if you want to study something, the best way to learn the basics is to understand the evolution, how the organ has evolved. These lines by Charles Darwin aptly summarize the theory of evolution. It is not the strongest of the species that survive, nor the most intelligent, but the one most responsive to change. And we have all studied and we all know how we human beings have evolved from being tetrapods to the present day modern human walking on two legs. And the fact that we have been able to walk on two legs have allowed us the freedom to work with our upper limbs and utilize our hands to do various things. That's the reason why we have seen all these modern day discoveries and inventions. So if we look at the spine here, we'll understand the major contribution to the change in posture has been because of spine. As we see in the tetrapod here, this is how the spine was, and now while walking erect, this is how the spine becomes. So the major role during evolution has been the development of spine, the adaptation that spine has taken, and as a result of this, the major brunt of evolution also is being bared by the spine. As we can see here, the entire load of the upper part of the body passes through the spine to the lower limbs instead of getting distributed among the upper and the lower limbs as it was in quadrupeds. So some scientists say that the spine is still evolving and it is still continuing to adapt to this change. Go to the anatomy now. The spine, as we know, is the central pillar of the body, constituted by 33 vertebrae or bones which are stacked one over the other, starting from right below the cranium, extending up to the pelvis. So for the descriptive convenience, we divide it into cervical region, which includes 7 cervical vertebrae, the thoracic region including 12 thoracic vertebrae, and the lumbar region including 5 lumbar vertebrae. The sacrum and the coccyx are fused to form one common bone. And this is how it looks, stacked upon each other to form a continuous pipe inside it, pipe-like structure through which our spinal cord and the nerves remain protected, as well as this provides the basic skeletal structure to our trunk. So this is how the individual vertebral body looks like. This is the anterior part, which is the vertebral body. These are the posterior elements, the spinous process, the transverse process, and this is the side view, the vertebral body through which the major part of weight bearing occurs, and these are the facet joints which join to subsequent adjacent to vertebral bodies and form the structure. And as we know, the spinal cord passes through the central canal which is created by the bone, and the nerves at each subsequent levels comes out of these intervertebral foramen. As we can see here, the spinal cord lying inside the vertebral canal and spinal roots exiting from each in between two vertebral bodies through the intervertebral. So this is how the spinal cord remains protected inside the vertebral body, and the nerves exit at each level, and we have named it from cervical C1 to 8, thoracic 12, and 5 lumbar. Now we come to the postures and curves. Our spine is not straight, and that's the reason we have been blessed with such amount of flexibility. We can flex to this amount of flexion to this amount of extension, as well as side flexion, rotation. All these movements are possible because of the flexibility and the curves that have provided. And the curves develop when we are in a newborn. The curve of the spine is C-shaped. There is only one curve. When the child starts to lift its head, the first curve, that is the cervical lordosis, develops. And when the child starts standing, that is when the lumbar lordosis, the third curve, develops. So when we see an adult spine, it is S-shaped with three major curves: cervical lordosis, thoracic kyphosis, and lumbar lordosis. Why do we need these curves? Why isn't it not straight? The reason is, if we had a straight spine like this, the amount of axial compression or axial load that it could resist would be very less. There is a formula, R is equal to n square plus 1, where n is the number of curves. So this explains, if we see the third diagram here, since our spine has 3 curves, n is 3, so the amount of axial compression that our spine can take is almost 10 times what a straight structure would have taken. So it adds that much amount to the stability. Now the curves again change with older age. As the age increases, the height decreases and the kyphosis again increases. This is mainly because of change in the posture, as well as the changes taking place in the intervertebral disc spaces. Now if we look at the spine from behind, it should be straight, and if there is any curvature to it while looking at it from behind, it could be scoliosis. Another important structure contributing is the muscles. Spine is surrounded all over 360 by muscles, and these muscles not only provide movement to the spine, but they are also major stabilizers of the spine while it is standing as well as while it is in motion. And muscles are the only structure in spine which can be modulated without surgery, and this is where the role of our physiotherapist comes, which we will talk about later. Coming to the most important aspect and interesting aspect of spine is the disc, the intervertebral disc. So as we all know, the vertebral bodies are separated or spaced out or joined by the intervertebral disc, and the disc material comprises of an outer tough structure called annulus fibrosus, and the inner part is filled up with a gel-like structure called a nucleus pulposus. This is a very interesting arrangement, because what happens is, in case of an axial load, it is this gel-like structure, nucleus pulposus, which distributes the compressive forces in all the directions, and hence decreases the stress and works as a shock absorber and prevents damage to the vertebral bodies. So the mechanism can be understood with something like this. Imagine a drum filled with water. So this drum is made of wooden planks which are bound together by these belts, these black colored belts. The water inside puts pressure on the surrounding walls. Now to some extent, these belts would resist this pressure. But if the pressure of the water exceeds the load what these belts can sustain, the belts would break and the water will come out. So our intervertebral disc also works on a similar principle, where the compressive or axial load it would resist to some extent, but when it exceeds its limit, the annulus fibrosus would break and the nucleus pulposus may come. The nucleus pulposus is made up of glycoproteins which have the unique property of retaining water and releasing it when loaded. So at night when we are resting, the disc absorbs water, and during daytime due to axial loading it releases water. So if we are almost 1 centimeter taller in the morning as compared to what we are in the evening, this property allows the disc to work as shock absorber. The intervertebral disc also does not have any nerve supply or blood supply, and hence it gets its nutrition by diffusion process only. Being avascular, the injuries of IV disc do not heal quickly. This picture shows how the load on our lumbar spine increases from lying down to standing, sitting, bending forward, and on lifting heavy weight. Even while sitting, the load on the lumbar spine changes with our posture. As we can see here, on sitting with forward reclined position, the load on the spine is almost double of that seen in standing position. That is how a normal disc looks like. Now we'll see what happens when we say the disc prolapses. So this is what happens. The first stage, the annulus, the green color is the annulus fibrosus and the pink color is the nucleus pulposus inside it. So the first step is on excessive axial compression or loading, which could be because of bending forward or lifting weight. The annulus fibrosus breaks. The next stage is the disc material comes out. The blue colored line is the posterior longitudinal ligament which prevents the complete extrusion, and this stage is called disc protrusion. Now if the PLL gets disrupted, the disc material further extrudes into the spinal canal. The last stage is disc sequestration, that is, the disc material gets detached from its parent disc. We may not see all these stages in all the patients. The prolapsed fragments of the disc compresses the neural structures around it and produces symptoms, that is pain and tingling numbness along the distribution of specific dermatome. The reason of pain is not only mechanical, but it is also chemical. The disc extruded material being antigenic, the body produces intense inflammatory reaction to this, and this chemical reaction is majorly the cause of pain in the initial few weeks after a disc prolapse. In subsequent slides, we would be discussing in detail about varied clinical presentation of disc prolapse and how we manage this inflammatory reaction. Thank you so much.
Good evening to all viewers. I welcome you all for this webinar. I am Dr. Shivanand Mai from Stavya team. Today I am going to speak on lumbar disc prolapse, mainly the clinical symptoms, how the patient present to us in the clinic. Nothing to declare, financial conflict, nil. Coming to the clinical presentation of this lumbar PID, it ranges from no symptoms to rapid paralysis. At one end, we can see that some patients with lumbar PID are asymptomatic, and at the other end, some patients will experience severe pain with motor deficits and with or without involvement of the bowel and bladder. So this severity of symptoms correlates with the acuteness of the disc prolapse and degree of compression of the neural element. So this degree of compression depends on the size of the disc. If the disc size is more, then the compression on the neural structures will be more. So this acuteness of the disc prolapse and degree of compression, size of the disc mainly gives the all variety of clinical presentation in the clinic. So coming to the common symptoms of the lumbar PID, they are mainly lower back pain or sometimes buttock pain predominantly. Some patients might be having radicular pain to the leg. Some patients might not be having typical radicular pain. and sensory dysesthesia, that is sensory disturbances along the nerve root getting compressed or which is getting irritated. List is the bending of the upper tongue to one side. As you can see in this picture that this patient is bending towards his right. So when we take a X-ray in standing position, we can on X-ray also we can make out the list. So this list occurs due to the compression of the nerve root by the disc. So the position of the disc mainly makes this list to occur. So whenever disc is at the shoulder of the nerve root, the patient bends to the opposite side. In this patient's MRI, we can see that there is prolapsed disc on the left side and patient is bending towards the right side. Whenever there is disc is at the axil of the nerve root, the patient bends to the same side. So depending on the position of the disc in relation to the nerve root, this list occurs on either side. Coming to the most common symptom seen in this lumbar PID, that is radiating pain, which usually occurs below the knee. So the pain radiating below the knee is significant and it helps in diagnosing lumbar PID. And we also ask patients about the walking distance, how far they can walk before taking rest or sitting down, or duration of sitting and standing at workplaces or in home. And the most common test which is performed is the straight leg rising test. So in this position, the patient will be lying relaxed in supine position on the couch, and the physician supports the leg and lifts it up with knee extended and the flexion movement occurring at the hip joint. So patient experiences pain when we are doing this test. So up to 30 degrees, most of the patient does not experience pain, but 30 to 70 degrees most reliable, and up to 70 degrees in normal patients also sometimes experience pain. Other test which is done in sitting position is the sitting SLRT. It is performed with patient sitting at the edge of the table with legs hanging down, and the physician supports the patient's leg at the ankle and tries to extend the knee joint. So during this procedure, the patient tries to lean backward or fall backward as he experiences pain because of the stretching of the sciatic nerve. So the other test is the cross SLRT. When the patient is having radiating pain in the right lower limb and the physician is performing SLRT on the left lower limb, patient experiences pain in the opposite, that is the inward limb. This is called as cross SLRT positive, and it mainly occurs whenever there is a big central disc herniation compressing on the bilateral nerve roots. Coming to the upper lumbar disc herniation in the upper level, that is L1, L2 and L2, L3 level with the compression of the L2 and L3 nerve roots, the common test which we do is femoral nerve stretch test. In this test, the patient will be lying prone on the couch and the physician hand supports on the sacrum, and with other hand holding at the ankle, he tries to extend the hip with knee in flexed position. So the patient experiences the typical pain in the anterior part of the thigh. So patient also gives history of sensory disturbances along the anterior and anteromedial thigh in upper lumbar nerve root compression. These symptoms of lumbar PID might be partially relieved with rest, activity modification at home or at workplace, and change in the position. In this photograph, you can see that the patient is lying down on the ground with hips and knee flexed at 90 degrees and legs placed on the chair. So the most of the patients with lumbar PID prefer to lie in this position with legs keeping on the bed, table or chair because they get relieved of pain due to the positional decompression occurring at the lumbar spine. So these symptoms of lumbar PID might also get exaggerated with trunk flexion, that is forward bending, prolonged standing and prolonged sitting in a single position, straining, that is during the nature's call, and maneuvers like Valsalva maneuver, cough and sneezing. So coming to the specific lumbar nerve root impingement and its associated clinical findings. we see that whenever there is compression of the L3 nerve root, L3 dermatomal pain along the quadriceps myotome will be felt with decrease in the quadriceps strength and possible decrease in the patellar tendon reflex. Whenever there is involvement of the L4 nerve root, the pain will be on the anterolateral part of the thigh and anteromedial part of the leg along the tibialis anterior myotome. There might be some amount of weakness in the tibialis anterior muscle with decreased patellar tendon reflex. Whenever there is involvement of the L5 nerve root, the pain will be along the posterolateral part of the thigh and anterolateral part of the leg and mainly along the extensor hallucis and extensor digitorum myotomes, and the numbness will be at the first and second two web space with decrease in the extensor hallucis power and no reflexes will be involved. Whenever there is involvement of the S1 nerve root, the pain will be mainly posterior aspect of the thigh and posterior aspect of the leg going towards the lateral malleolus, and the numbness will be in the sole of the foot and posterior aspect of the leg, that is calf region. So this pain or numbness in the calf region should be differentiated with the thromboangiitis obliterans, that is TAO, which occurs mainly in the smokers. This S1 root compression might also be showing some weakness in the gastrocnemius and peroneal muscles with decrease in the Achilles tendon reflex. Cauda syndrome is an emergency condition that is red flag in the spine practice which requires urgent emergent decompression. So it occurs due to large lumbar disc herniation significantly compressing on the cauda equina structures. It clinically presents as bilateral lower limb radicular pain with motor weakness. Main characteristics are the bowel and bladder dysfunction, involvement of the bowel and bladder and saddle or perianal anesthesia with urinary retention. So this condition requires urgent treatment. So if this condition is not treated, then patients will be having urological and sexual dysfunction in the long run. To summarize about the common presenting features of the lumbar PID, mainly they are radicular pain and numbness along the nerve root involved, sensory disturbances, motor weakness, and sometimes muscle atrophy from prolonged compression of the nerve root or disuse of the specific muscle for a prolonged period with or without involvement of the bladder and bowel. Thank you for your attention.
Good evening, everyone. I am Dr. Devanand from Stavya Spine Hospital. I am here to discuss about the lumbar disc prolapse conservative management. So this paper published in Global Spine Journal in 2020, the assessment of non-operative management, the herniated disc prolapse population. They have studied over 10 years, out of which they have included 2,77,000 odd patients, and 97% of them were managed successfully, and only 3% is the surgical rate. So the basic X-rays, most of the times they show normal, and the MRI, once it is taken, it will be either showing a disc prolapse in one of the stages, either a disc bulge, protrusion, extrusion, or a sequestration. And most of the times the extrusion or the sequestration are managed conservatively. So in this era of, you can see the robotic spine surgeries, the surgeries are being advised for each and every case. Most of the cases of lumbar disc prolapse are initially managed conservatively. Nearly all the cases, right from day 1 pain or day 7 or day whatever, but the number of cases are treated conservatively. Most of the patients, they come with significant stress and lot of MRIs taken, lot of doctors suggesting surgeries, but the main thing lies there with the patient education. You need to counsel them that do not panic, and the drugs, we all know that the drugs we use are NSAIDs, muscle relaxants. If not, then we go for the epidural steroid injections and some sort of physiotherapy. Since long, the main conservative management that is advised is a bed rest, but since 1970s it's been proven that not more than 1 to 2 days of bed rest is recovery. The more the bed rest, the more the muscle weakness. So more than 48 hours, the recovery time is increased and the paraspinal muscles, they become more weaker. As you know, the painkillers, patients ask, so should I take painkillers? Are they hazardous for life? No. The disc prolapse itself releases some inflammatory mediators which irritate the nerve root and cause leg pain and a sort of low back pain. So to reduce that inflammation and edema in and around the nerve roots, we give painkillers, which are the non-steroidal anti-inflammatory drugs. These are usually combined with antacids and can be taken over a period of 1 to 2 weeks. But long term, it has no benefit and it has few side effects also. Once it comes to muscle relaxants, a few of them argue that is the initial muscle spasm is protective. That means the patient is becoming protective by himself and it doesn't allow much movements and he doesn't allow the disc prolapse to be increasing. Yes, that is right. But still, the muscle relaxants have a role to play in the initial treatment because they give significant symptomatic relief to the patient. Right from hot fomentation to ice packs that are given in the home, there are other modes of physiotherapy. As you can see, the traction, shortwave diathermy, and interferential therapy. The traction is usually used for few cases of lumbar disc prolapse in which the shoulder disc prolapse is in the shoulder part, not in the axillary part. It gives a sort of muscle relaxation and gives symptomatic relief to the patient temporarily, as well as this shortwave diathermy and IFT. They also give a good symptomatic relief in the initial periods. So the next question is, how long is this conservative management is going to help? A minimum of 6 weeks. If the pain is gradually decreasing, we wait for a period of 6 weeks and a maximum of 3 months. But still we caution the patient. But if there is any increasing pain along, even if the patient is on NSAIDs and the pain is increasing, or there is any neurological deficit which is seen, like foot drop or the weakness of the toes or difficulty in wearing the slippers, then the patient is advised to come back to the hospital. The next mode of treatment would be epidural steroid injections. These are not oral steroids, these are local steroid injections that are given in the spine. They can be given in the OPD basis. They are usually given as two ways: the caudal epidural steroid, which is given in the sacral hiatus, and the next method is transforaminal epidural steroid injections or selective nerve root blocks. These injections are given in the operation theater under the image guidance intensifier, and a spinal needle is used to give these injections. So the procedure involved is we uh, progress the needle under IITV into the space which actually lodges the disc and the nerve root. So the foramen and the disc, in and around that area there would be edema and inflammation of the nerve root. So we give initially a contrast which will tell us exactly where the nerve is going and the probable place of edema, and we inject steroid along with local anesthetic, which will give significant relief to the patient. But mind that only 50 to 60% of the patients are relieved with this, and few of them get relief for days and some for months together. This transforaminal injections or selective nerve root blocks, they give a buying time for surgery. Patients come back to us and say that I am more than 50% better. Should I go for surgery or should I wait? So if it is more than 50% symptomatically better, we need to just relax, wait and watch. There are chances that it goes off completely normal. If it is less than 50% better, what next? Or 50% better, what next? So we do what is called as a contrast MRI. The contrast MRI is a procedure in which the contrast is injected and the contrast, it accumulates in and around the disc. If there is enhancement on the contrast MRI, it shows that the disc is getting vascularized and it may resolve on its own. Or if the disc is not getting vascularized, that means the patient may end up in surgery in the future, near future. Few of them ask when to go back to work. Our standard answer would be work within pain limits. and your body will dictate you how much you can work and what pattern of work are you in, like light work. A patient's having computer work, software, sitting job can go back easily to work within a week. But if the patient is having a heavy work, we need to restrain him at least for 4 to 6 weeks. We all we should all tell the patient if he has any symptoms of bladder, like if there is any difficulty in passing of urine, or if there is involuntary micturition of urine, these most probably a cause of cauda equina syndrome. These patients may have cauda equina syndrome, in which the bladder symptoms and bowel symptoms they start, and sometimes the patient may have progressive neurological deficit, numbness in and around the perineal area and the bladder area. So these are the cases which are supposed to be the emergency in spine surgery, and they need to be surgically treated. As you can see in this image, most of the patients ask what to do, what not to do, which position to adapt. I mean, there are these are the pressures on the left hand side, and you can see the maximum pressure while standing is in forward bending with the knees and hips in extension, and in the same position lifting weights. We need to avoid this position so that the intradiscal pressure increases. In the same way, sitting and lifting weight in this position also increases the pressure in the disc, and it may cause the disc prolapse to further progress. These are the ideal sitting positions. You can see you should not be just relaxing in the chair like this and sitting your foot on the front desk or something like that, but this is the ideal position where the head needs to be stable, the chin tucked, the hips and needs to be 90 degrees, and the level of your eyes should be in level of with the laptop. And in the same way, the sitting positions at home needs to be modified in this way, and when you are lifting something from the ground, this is the wrong way to lift it. This is hip and knee bending, in which there will be less of intradiscal pressure. This image shows the ideal standing position. You can see the hyperlordosis or hyperkyphosis is bad for health, and it puts more pressure on the spine. So this is a good posture which needs to be maintained, in which the ears are to be aligned with the shoulders and the hips and knees in the straight position. The sleeping position, most of them they advise sleeping on the hard surfaces or the too much soft mattresses. No, the ideal mattress would take this position, I mean the curves of your spine, where it is not completely bent when you are sleeping. So these are the ideal sitting and standing and sleeping positions which you need to adapt, so that your routine life also will be good. And in the last, most of them, the young patients, they have a small disc prolapse and they go to what is called as local massage centers and malish, and they keep the pressure so much that most of them they come with a huge acute disc prolapses with sudden increase in symptoms and sometimes cauda equina syndrome. So these absolutely need to be condemned, and they should not be encouraged at all. So in the last slide, I would just like to tell you that with all the conservative treatments, 97% of the disc prolapse patients, they get better, and only 3% require surgery. So conservative management is still here to stay, and I wish all the patients will be treated in the conservative way initially, and then accordingly advise surgery. Thank you.
Good evening, everybody. When, why to operate, how to operate, what outcomes to be expected, and what are the complications which are expected. That's what we'll talk in this last lecture. And you would be surprised and should be happy that 10% of the patients only need surgery. So it is all talk about that 10% of patients who need surgery. The outcome is predictable and they are reasonable, and the immediate outcome is very good. The indications of surgery are absolutely must and is dictated by the surgeon if it is a cauda equina syndrome or progressive deficit. Otherwise, in all cases of disc prolapse, it is a relative indication and it's a shared decision, and it's the patient who would be taken into confidence by all means before you go in for surgery. So the surgery need in those cases would be non-relief of symptoms of pain, a disability or deficit. This is what is the classic teaching, and this is what is followed till date, because the gold standard studies say that the natural history of the disc prolapse is very good, as has already been very wonderfully shared, discussed by Devanand, Shivanand, Ravi. And in all the cases who are chosen for surgery, the clinico-pathoradiological correlation is a must. If you have not got the pathology right, your outcome is going to be as such poor. Now I'll talk about something which I am too much fond of and I'm passionate about, that is the transforaminal endoscopic approach for discectomy, wherein you put in the endoscope in this direction transforaminally to remove this disc piece which is there, and the patient is put in the prone position with a local anesthesia which is given. In under image guidance, you put a needle in the transforaminal area at the location where you want, and over that you put up the endoscope, and this is where the endoscope goes below the facet beside the root, and this area is called the Cambin's triangle, and it is minimalistic approach to the discectomy because of the size of the incision is 6 to 7 millimeter, and the blood loss is hardly anything with the local anesthesia being used, and it just targets the fragment and does not leave any footprints or any damages to the external area which is there. And that is this is the band-aid surgery what we call, and I can or we can handle all the types of lumbar disc prolapse by a transforaminal approach. And to cite few examples, this is an extraforaminal disc prolapse in this location which is visible, a transforaminal approach taken, and you can see the post-operative MRI wherein the decompression is adequate, the fragment is no more there. The fragment is no more there. Another example, this is a big central disc which is there, and this is an upper lumbar disc prolapse which is there, down migrated. You can transforaminally go there, remove the disc fragment, and this is the post-operative MRI which is there. Migrated disc prolapse needs little bit of foraminoplasty, that is widening of the facet which is to be done, and you can remove these migrated fragments also. This is the pre-operative image and the post-operative image of the same patient transforaminally operated. An up migrated L4-5 disc which is visible like this in this location, and it is in the hidden zone, and you can remove this, and this is what is the post-operative MRI showing good removal, decompression. And uh, this is the pre-operative MRI of a recurrent disc already operated laminectomy 1.5 years back, and he has got a recurred disc, and he was not ready for the open surgery by the same surgeon, so he came to us and we did a transforaminal approach discectomy, and I could remove the fragment, and this is the decompression which is there. Patient is absolutely fine, and they are classic examples, and they keep saying good words about you. These are the extended possibilities for biportal calcified disc, like I have put the endoscope bilaterally to decompress calcified disc like this. This is complete myeloblock which is there. This is the calcification. This is the calcified disc which is there. And this is the outcome which you have. You have removed this part. You have decompressed it completely. This is the myeloblock which has opened up. So technique wise, if you put your endoscope in the transforaminal region, this is the visibility inside the endoscope which you have on the screen, and you are actually using the small instruments to do a subannular decompression. And once that subannular part is removed, you cut the annulus, and after the annulus is cut, you remove this fragment which just comes out with a ease, and it is delivered out through the endoscope. This is a small fragment which would be there in a paracentral disc, and the patient will be completely relieved per operatively. Consciously you can check the patient, and this, if you see the endoscopic view here, you can again see the dura which is completely decompressed because the fragment is completely now removed, and these are the position of the endoscope which is there, you can see here. So this is what you can achieve with this. Now let's talk about the conventional discectomy which we all have done many years back, wherein you do 2 to 3 levels of midline exposure which erasing of all the muscles from the midline, and then you have the uh, spinous process and the lamina and the ligamentum flavum. And in a laminectomy you would remove a lamina here, you remove this lamina, you see the dura there, you retract the dura, you go in, you remove the disc fragment and decompress the neural tissue. So disc is ventral to the dura and we have to retract the neural tissues, and we have to manipulate very carefully so that we don't induce any damage. And conventional hemilaminectomy means one-sided approach only. When you remove a part of the lamina and the ligamentum flavum on one side, this is one-sided exposure which you do. This was smaller than what was the conventional whole laminectomy. And in fenestration you would do even smaller incision, and wherein you would remove only a part of the bone and the ligamentum flavum and remove this fragment. So this is fenestration. What was the problem with the conventional surgeries is that there was no magnification which was there, and there is no light, or there is hardly any light, and you are scolding at your OT boys. So what was the problem? There was a cone approach which is there, and wherein an approximate exposure of 7 centimeter to 10 centimeter is needed for a pathology which is just 8 to 10 millimeter. So for a pathology like this, which is a disc prolapse, what you end up needing is a cone-like approach here. So this is what we are talking, an incision, because you cannot see inside this approach. And herein where the disadvantages were completely clear, that there was more pain, more admissions, incision, scar, blood loss, morbidity, big surgery. Earlier, 15 years back, 20 years back, it used to be a big surgery when it was done in the institute. Rest and mobilization was required and given to most of the patients with belt, and iatrogenic instability was a common occurrence, with residual back pain because of the muscle damages, and the instability is a common thing. What is the current trend and the scientific advance is preservation of soft tissue, bone, and the minimalistic approach. And the incisions which were which were there, which were measured by tape, are now past, because you do a microscope assisted lumbar decompression or tube assisted microscopic surgeries, wherein your exposure is this with the microscopic view, and the light which is put, the incision may be as small as a 1-inch incision, and these are the tubular things which you use for this, and these patients are mobilized quite fast. So the disadvantage of no magnification and light was completely taken away by use of scopes, and these scopes were as small as like a loop which is there, which is also a microscope, which gives you better view, but the incision was still there. Your visibility increased, your light put more, but your incision size were not very small with a loop. And it was microscope which is the thing which changed the size of the incision significantly and improved the outcomes as well. There are many other techniques which is there, and to zero in on touch on few of the techniques is that this is interlaminar endoscopy, wherein the endoscope is locked onto the posterior elements interlaminar region, and the working instruments also goes through in this endoscope only. And because of that, these endoscopic instruments are very small, and least manipulations are done with this interlaminar endoscopic surgeries also. Now something which is coming up is interlaminar unilateral biportal endoscopy, wherein there are two ports. One carries the endoscope inside for light and camera recording. At the same time, other port uses conventionally big instruments to reach to the scope. So this needs more triangulation to remove the discectomy, and it is also interlaminar, but has got significant advantages as compared to the conventional surgeries. Few lines about microscope. Microscope, as I said, loops and externally mounted microscopes are microscopes, and they are exoscope, outside the body light source, outside the body magnification. An endoscope is something wherein you have a channel which carries the light inside, and the magnification is there, and the working channel is also built inside the endoscope. So is a microscope an endoscope? No. But an endoscope is a microscope? Yes. Coming more to the postoperative management of all patients who are operated by any of the methods, there is significant amount of confusion about all these aspects of bed rest, mobilization, climbing stairs, getting back to work early, exercise, belt, bending forward, sexual life, sports, weight loss, and this all talk has been because of only one reason: to prevent the recurrences, and suggested by most of the surgeons. The reason for this are usually the fear of the surgeon, and there is no scientific evidence about it. And the basic thing that should be suggested to the patient is go according to the pain tolerance and the pain and the recovery. So the patient themselves should guide them towards the faster recovery. This was one of the articles landmark which was there by Eugene Karagi, wherein 152 patients were made to do all the activities without any restrictions, and they didn't have any complications which was more than that of the persons who were subjected to significant restrictions. So that was a significant eye-opening paper which was there. And when to operate, the classic guidelines is for failure of conservative treatment of relief for 6 weeks, but more than 3 months the outcome decreases, so all surgeries should be done before 3 months. And now this decisions for a surgery has reduced to even 3 to 6 weeks, looking to the non-tolerance of the patients, and patients don't follow you. They are not ready to wait or lose their work capacity, the productivity they don't want to lose. If the surgery is done for a neurological deficit, then that is called functional recovery surgery. And in that case, these are the papers which have been published, which says that small one root deficits are insignificant on a long term, and the patient develop enough compensatory mechanisms to overcome it. So a neurological deficit should not be a reason for justifying a surgery except for cauda equina syndrome. Is it so easy? Pitfalls are there and complications are there. You have to remember that. And poor pathology of the disc prolapse are prognosticators for the surgery. And bulges, these are the conditions which gives poor result with simple discectomies. So bulges, protrusions, central disc are big, are known to give more problems. Calcified disc, patients with more stenosis attached, patient with wedged disc, chronic mechanical pain with narrow constitutional canal with instabilities, these are all poor prognosticators. And fusion may be added to this group of patients, and tailoring is required provided that patient is ready to understand these things. Complications do occur in all surgeries, like failure to relieve the symptoms, level failure, neurological deficit, cauda equina syndrome also can occur, infections, instability, iatrogenic injury to any structures can occur and to be prevented. Small window surgeries are not recommended by conventional books of ours also. Even Benzel, it says that small window surgeries are not recommended. This is classic slide wherein it is described that if there is a disc prolapse which is there here underneath the dura here, your first incision should be at the lateral aspect of the annulus, and from there you should do a subannular decompression here and make a space like this, and then you have to deliver the fragment into the space created and pull it out like this, rather than directly seeing a fragment and pulling out. This is something which you always have to remember, because this is one of the paper which was again eye-opening in 2010, which said that 15% of all the cases of cauda equina syndrome are due to surgery itself, interlaminar surgeries. So the least manipulation is what is you are aiming, and the least manipulations are obtained as you go more and more oblique. So that's why fusion surgeries have given better outcomes because of least manipulations of neural tissues, and at the same time transforaminal endoscopic surgeries have given better outcome. It's not all. There are multiple patient factors to be considered before you can give a very good outcome, and these factors are very important, like a demanding patient or what is the demand of the patient you should know. Lesser motivated patient or lesser disability patient, you will not be able to give significant outcome to this group of patients. Personality of the patient is to be assessed, especially the female patient, because they have poor tolerance and less acceptance, so they may keep on complaining for residuals which is there. So you have to be careful, and especially for those places where workman compensation is important, You have to understand, and this is especially in the Western world. Non-psychosocial factors like uneducated patients may not be able to understand the need of their surgery, and fusion surgery may become a necessity for this group of patients for cost as well. Heavy laborers, heavy travel involved, sports activities, unemployed people, obese people may necessitate a fusion surgery, and you have to think twice before doing a simple decompression surgery in this group of patients, and you have to take them into confidence before doing that. Medical comorbidities, smoking, etc. gives poorer outcomes, and you have to always consider this before surgery. Remember, before surgery. That's why we are talking about non-surgical factors of the patient, conventional or advanced surgical technique. Always avoid all these negative prognosticators of the pathological disc what we talked about, and also the patient factors, because the primary aim of any surgery is nerve root decompression, removal of the compressing element only. The advances, whatever it may be, the surgical decision is more important than any surgical technique, and patient factors and selectant is always the biggest important thing, which gives a more predictable outcome. Thank you.
Greetings from Bharatar Dave. I'm going to speak the summary of today's webinar on behalf of the consultants team of Stavya Spine Hospital. What is happening in the clinical scenario is how we all do the conversation with our patients. We often use this word, your disc is torn, and that makes patient worried. Your disc has prolapse, it is misplaced, that makes patient much more worried. There is gap in the spine, that even also is worrisome to the patient and relatives as well. And we often see the prescription rest for 2 to 3 months. That is something which is detrimental, and that will lead to a lot of issues. And often we get the patient who gives us information, if you do not undergo surgery, you will develop paralysis. So all these things gives us a negative effect, and that also increases the anxiety, and that also gives a lot of psychological issues. The lumbar PID and the back pain is treated by many, starting from orthopedic surgeons to neurophysicians, and also by many quacks. And many of these hospitals and the nursing homes and even the clinics and even the quack clinics, they are all run because the natural history we know that it's going to resolve on its own. But still, we all take that advantage and we treat these patients, and we do not share this real information to the patient. And pain is something which is still, to me, is a big invisible monster, and pain has got lot of aspects and something which really is difficult to understand from the patient perspective and even the doctor's perspective as well. Patient comes to us with agonizing pain, and as Albert Schweitzer has said, we must all die, and we should really do best for this terrible lord of mankind, and that is pain. And it's been depicted in the different museums in the form of sculpture and the pictures as well. Would like to narrate about the psyche of our patients who are in the real pain. They do not want to suffer, they want the immediate cure, and most of the time they correlate all the spine problems, they are the same. So anyone who has the cancer or the infection, they all will have the back pain, and they are all considered as the same problem. And there are a lot of myths for the pain and management as well. And there are many alternative therapies starting from acupressure, acupuncture to all other alternatives like quacks treatment as well. And all these have the natural history with them where the natural resolution is going to occur, and they get the credit for the same. So in our branch as well, our training varies, they are different, and really people want to have the double check as well. And most important, most of the patient, they do not stick to the same doctor, and that is where we do not have the follow-up of our patient as well. So it's difficult to sort of tighter and have the patient's input all the time. So I'm going to talk about facts. I would say the fact has been described by Dr. Devanand very well, that 90% plus they resolve on its own. And I have a couple of share. You can see that this patient has got the big disc which was there, which is seen there in the sagittal views. And after 6 months, the new MRI shows complete resolution of the disc which was prolapsed, and it was a big size. So this shows that the disc prolapse is something that resolves naturally as well, and it takes about 2 months or 3 months. So if it starts resolving, I think it's better we stick to the conservative treatment for such group of patients. Same way, another example of 21-year medical student, 2002, had significant radicular pain, and it healed with the disc cyst. And this disc cyst, as you can see here, that will never give compression, and patient symptom had completely gone. So we took this image, only make sure that this has disappeared completely, and this patient had complete resolution of the symptom. This disc cyst does not need any treatment. What are the myths about the disc prolapse? People say that it will lead to paralysis. More often than not, the doctor also says the same. Relatives also keep on talking about the paralysis. Most of the relatives, they will say, oh, one surgery, second time it's going to need surgery. So recurrence. So we'll talk about the same as well. And most of these surgeries, most of the people in the society, they say it's a poor outcome. Let us know the difference of herniation and disc degeneration. Herniation occurs at the younger age, although it can happen at the older age as well. Annular tear occurs and the nucleus pulposus comes out and gives rise to pain in the back initially because of the ligament stretching, and afterwards the nerve root gets irritated and back pain gets relieved. And in this sort of cases, the nutrition of the disc is affected secondarily, as mentioned by Dr. Ravi in his first talk. Degeneration is an aging phenomenon. It affects the end plate, and because of the end plate sclerosis, the disc nutrition is affected, and it leads to desiccation, fibrosis, and cleft formation, and healing with the fibrosis. So these are the two examples of disc degeneration. Internal disc disruption, that is where chemical neuritis is something which brings the patient to us. Chemical of the nucleus pulposus is so irritant like an acid, and it gives significant pain and disability, but that can be treated conservatively, and classically it will be seen as black disc. And the isolated disc resorption is another type of the disc degeneration, where the disc degeneration has occurred and there are osteophyte formations seen as well. So these are the disc degeneration patterns which we often see in the day-to-day clinical practice, worth knowing as well. So this disc compresses and swells 1 million times per year, and this disc is a neural and avascular structure, and because of that the disc healing does not occur normally, and this disc healing does not occur, hence the process of healing occurs with the decrease in the height, and that is where the facet dysfunction will occur, as shown in the first talk by Ravi. So the disc prolapse treatment is well established. The results remain variable. In the first 2 years, the result is quite good. That is 90% plus good resolution of the symptom. Afterwards, the result goes down because of the decrease in the disc height, and the residual back pain and occasionally leg pain can occur as well. And that is where patient will come back to us. And if patient is doing regular exercise, then patient won't need to visit clinic again and again. So very important, after the surgery, they have to really have the strong extensors muscles and even the abdominal muscle as well. That will act like a belt, and that will not give rise to the facetal dysfunction. Let us talk about the red flags. We should warn our patients about the bladder bowel symptoms and weakness that develops in the leg or foot while we are treating them conservatively. While patients are on the conservative treatment, we should share with the patient about the increasing neurological deficit, unbearable excruciating pain, which we call this as a nerve cry, bladder bowel habit change because of the compression on the nerve, and the most important is manipulation by the quack, which is the method of treatment in our part of the world, which gives rise to bladder bowel symptoms after the manipulation. We always talk and discuss, and we have the shared decision with the patient about the treatment plan. We say we do not sell the surgery, we do not frighten the patient, let patient decide and plan the surgery. Let us all follow the good clinical practice in the form of no bed rest, activity in the pain limit. Majority have the good response with the non-operative treatment, and as we all know, MRI gives us 20 to 30% false positive in the asymptomatic patient as well, the disc prolapse. Surgical treatment is superior, but it is for maybe 1 or 2 years initially. You cannot let patients suffer for that long. Disc is going to degenerate whatever method of treatment we give. Height is going to decrease and patient is going to have the facetal dysfunction. And we always should insist on the clinico-radiological correlation. Only that is the major guide for the treatment plan. Meaning what? Surgery is indicated after specific investigation for that particular condition, after confirming the diagnosis with the radiology, with the X-ray, with the MRI, and after failed conservative treatment. After failed conservative treatment. So we usually advise that we should wait for good few weeks. If patient is responding to conservative treatment, then patient usually will have good treatment as well. Successful lumbar spine surgery is dependent all about the clinico-radiological correlation. Patient's natural history should be discussed, and after that we should really advise the patient that your symptoms are matching with your imaging studies, and that is where you probably need intervention. So the Hippocrates oath, do no harm. In this recent technological era, I think we should be doing good for our patient. We should be doing best for our patient. We should not operate if there is no clinico-radiological correlation and if there are no convincing signs. So the take-home message is, let's be precise, let's be authoritative. Sometimes patient comes demanding, I want the surgery because I have significant pain. We should be narrating the natural history to the patient. We should know our limit, and we should really say, no, you do not need surgery. Earning we always consider secondary, and primary is our patient care. Let's be honest, let's not give false hopes and misguide our patients. Hello viewers, thank you for active participation in this webinar. Thanks to our hospital staff and our doctors team, and thanks to Torrent IT team. Let us now have the question answer session. Good evening, everybody. Thank you all the viewers. I have few questions, and I'll start with the question to Dr. Ravi. You can unmute yourself. And the question is, vitamin D deficiency, can it lead to disc degeneration?
No, vitamin D deficiency has not been directly linked to disc degeneration. However, it leads to other metabolic bone disorders which can indirectly affect the health of the spine.
I have a question to Dr. Ajay Krishnan. What percentage of the patients they have after surgery, the adjacent level problem. Dr. Ajay? I think Dr. Devanand, you can answer this question. You can unmute yourself.
Yes, sir.
What percentage of the patient after the surgery? There is a question from Dr. From Junagadh. He's asking after how many years and at what percentage of the patient they have the adjacent level problem after the lumbar surgery, either laminectomy or fixation.
Yes, sir. That's a good question. We have a lot of data which says that there are adjacent level problems after fusion surgery, especially when there is fixation at the L4-5 level or L5S1, because of the excessive movements or excessive strain at the adjacent level. But the data with respect to laminectomy and discectomy of the adjacent levels is not yet recorded. But however, the disc regeneration once is starting at one level may happen at the other level. The adjacent segment is probably a misnomer in case of a laminectomy and discectomy, but may hold true for the fusion levels. The percentage of patients, it's difficult to say. For the fusion, yes, it is good recorded number, but laminectomy, discectomy, still not yet recorded.
Yeah. I think in the similar context, there is a question we can ask to Dr. Ajay. What is the reason for this recurrence? Dr. Ajay, you can answer this. What is the reason for the recurrence? Hello? I think
Yes, sir.
what percentage of the patient after the surgery? Dr. Ajay, you can answer this. What is the reason for the recurrence? He's asking after how many years and at what percentage of the patient they have the adjacent level problem after the lumbar surgery, either laminectomy or fixation.
Yes, sir. That's a good question. We have a lot of data which says that there are adjacent level problems after fusion surgery, especially when there is fixation at the L4-5 level or L5S1, because of the excessive movements or excessive strain at the adjacent level. But the data with respect to laminectomy and discectomy of the adjacent level is not yet. But however, the disc regeneration once is starting at one level may happen at the other level. The adjacent segment is probably a misnomer in case of a laminectomy and discectomy, but may hold true for the fusion products. The percentage of patients is difficult to say. For the fusion, yes, it is good recorded number.
Okay, the next question to Dr. Ajay. There is a question. Is endoscopy expensive? Dr. Ajay, is endoscopy expensive? You can unmute yourself.
Endoscopy is hello.
What percentage of the patient after the surgery?
Ajay sir, please.
Hello. Am I
Yeah, you are
audible?
live. Can you?
Am I audible?
Yeah, you are audible. Please.
Yeah. So the recurrence is not at all in hands of any of the persons. Definitely, it would be a very big difference made if there is significant amount of physical strains the patient is taking. But for normal life activities, it does not cause big problems. But at the same time, if you relate with the sports injuries, there are so many number of people who are into sports, heavy sports, high energy sports. They develop this prolapse, they get conservatively treated, that resolves. Many of them undergo surgery also, but after surgery also they resume to their routine sports. But the thing is that those sports cannot be continued for longer time because these injuries are persistent. And at the same time, like there are many laborers which are there are females who work in their home without taking care of the back. These all people have a tendency to repetitively get their disc injured. The way Dr. Bharatbhai already told you, there is 10 million times a disc comes under strain for a year's normal activity. So somebody who is straining his back because of activities. Though the research is not saying this, the research does not say that a particular type of activity goes in direction of recurrence, but in practical experiences it has been noted that the only thing that the patients come back to us also is, especially with those group of patients who are not able to enforce certain lifestyle modifications. These lifestyle modifications are not big modifications. Most of the routine activities the people are able to do.
Thank you. Question to Dr. Shivanand. How many days of bed rest is advised? Can you just elaborate on that?
Yes, sir. So usually bed rest is advised for 2 to 3 days when pain is very severe. After that, patients can start their day-to-day activities or in-home activities. Only the activities which increases the pain should be avoided. Other routine activities they can continue. Patients can continue within the
Um,
pain limits.
yeah, the same question to Dr. Devanand. People sometimes put the lumbar traction with the bricks on. There are many consultants still they practice like that. Is what is advisable?
Uh, the lumbar traction, whatever is done by the physiotherapists at their center, they actually have a specific instrumentation which gives traction at the level of lumbar and pelvic area. And the bricks, they do work for some extent, but this lumbar traction as a whole, it acts like a indirect muscle relaxation. So the natural history of disc prolapse is not altered in this. Only thing is they get a symptomatic relief at that time. Once the traction is removed and the patient is on their toes, after some time, the pain is the same. So I think the traction is not that much helpful in case of natural disc prolapse, but it definitely is helpful for the lower back pain.
Yeah, thank you. Question to Dr. Ravi. Is this disc prolapse genetic?
Uh, well, it's difficult to answer because the literature doesn't say that. There are a few literature studies on the genetic susceptibility of lumbar disc prolapse and degenerative disc disease, but none of the literature has been able to conclusively prove the hereditary nature of this.
Yeah. Thank you. I think the studies are going on about the same in the lab. It has not come to the clinic yet. Um,
However, the
question.
literature doesn't conclusively have evidence about it.
Yeah. The question to Dr. Ajay is this O-arm and navigation. Does it have any role in this disc prolapse? Have you tried sort of using it in the endoscope, the navigation system?
Yeah, I have used in the navigation system, but at the same time, for using in the navigation, you need special needles. That is one. Second, the other problem that happens with this is that for having a acquired image, the most important thing for OARM and navigation is the static acquisition, and there should not be any movement. These patients are under local anesthesia, and by default, if it moves by say few millimeters also, it can be catastrophic. That is the reason why it has not actually penetrated into the practice. But at the same time, there are multiple things which are getting an attention, and most of the endoscopic companies also are trying to get a navigation system incorporated into their existing systems. That may reduce the learning curve probably over a period of time, but it is still in the early phase.
Yeah, thank you. There is a question to Dr. Shivanand. How can we improve our posture? Dr. Shivanand, how can we improve our posture?
Yes, sir. The posture, to improve posture, main thing is while sitting and standing, we should be sitting and standing in proper posture. We should avoid improper postures and do regular exercises, back strengthening exercises to build up the muscle strength.
Yeah. So it's mainly muscle strengthening exercise.
Yes.
Yeah, we often advise the patient to stand next to the wall in order to maintain the posture, and basically extension exercise are very important. There is a question from the audience asking about the osteoporotic bone and the disc extrusion. I think Dr. Ajay, you can answer this osteoporotic bone and the disc prolapse.
The disc, whenever it prolapses, it has got a tendency to prolapse to different directions. A disc can prolapse anteriorly to make a limbus vertebra. A disc can prolapse into the vertebral body, a normal vertebral body, to make a Smorel's node, or it may tear across through the annulus and nucleus pulposus to present as a disc prolapse intracanalicular. But at the same time, what is noted is that the annulus and the nucleus, annulus and the PLL, posterior longitudinal ligament, is a more stronger structure and it doesn't easily give away. So even in the disc prolapse of normal people, it is now believed that actually the rupture or the breakage of the annulus fibrosus and the PLL is occurring at the bone junction, and the fragment is moving out through a vent in the bone. Actually, that is in normal also. For an osteoporotic patient, if you see the classic appearance of an X-ray itself is a codfish appearance. That means that the disc has a tendency to bulge into the osteoporotic bone, and the disc is stronger than even the end plate. So that is what is the thing. But there is no study that would say that, or has come out with a result that osteoporotic patients will have a particular type of disc prolapse. There is no study on that.
Yeah. There is a question for Dr. Ravi. Do you use steroid in order to treat the disc prolapse? And if yes, when?
Okay, so as we have discussed in the previous talks, the reason for pain in disc prolapse is not only mechanical but also chemical because of the inflammation. So we do use anti-inflammatory agents, which includes steroids in some cases. However, whenever we use steroid, we take care of about the profile of the patient, the comorbidities of the patient, and whenever these steroids are used, they are used for a very limited short period. A better way of using steroid that we do is a root block or an injection near the nerve root which is getting irritated or inflamed, so that the steroid acts only at the local place and does not have its side effect all over the body.
Yeah, thank you. There is a question which I would like to answer. Is the neurokinetic therapy, kinematic therapy, can prevent the disc compression? Well, there are many therapies, there are many modalities, there are many different new things coming up. But at the moment, there are a lot of things that has come in the window and even has gone out of the window as well. So all these things, they keep on coming. At the end of the day, you really need to have the strong muscles in order to support your back. And like a classic experimental study shows, if the muscles are attached to the vertebral column in a dead body specimen, up to 25 kg weight, it will withstand the forces. It will withstand the 25 kg weight. But if the muscles are detached, then only 5 kg weight and it will collapse the whole skeleton. So muscles have got a lot of role in the stability of the spine. And the same thing applies to any disc prolapse case or any disc degeneration, that if the muscles are built properly, then they will certainly strengthen the skeleton. There is a question to Dr. Ajay that the disc degeneration, do you use for all the endoscopic surgeries? Can we use it in all the disc degeneration cases?
Endoscopy can be used in all the indications of disc prolapse, and it would even be more fruitful in degenerated cases, because in degenerated cases there are multiple degenerations which is going on in the body at multiple levels, and the pathological level is only one. and the patient gets very good outcome because the fragment is completely free usually. Discectomies, to start with, at least for beginners, it is going to be difficult when you are doing in a young patient, because the young patient disc, annulus, everything is strong, and you need to get across to the fragment to deliver it. So young patients are not the first choice to start with, those who are initially starting their practice in endoscopy.
There is a question to Dr. Devanand. D7 vertebra osteoporotic fracture. It's a general question, but we will be addressing into the next webinar, which is going to be on osteoporosis. But as the viewer has asked, D7 vertebra fracture, what could be the management, particularly in the osteoporotic patient?
Yes, sir. D7 osteoporotic fracture vertebra management depends upon two things. First thing is what is the duration, how long has been the fracture, and most of the osteoporotic fractures, they heal on their own with minimum amount of bed rest, and we give calcium supplements. Along with that, we supplement it with Forteo. But if the patient, even after 6 to 8 weeks of conservative management, doesn't heal, the fracture doesn't heal, and it goes into non-union, then the patient may require surgery. It could be different types of surgeries, like we do vertebroplasty, where we put in the cement into the vertebral body, or if the patient has neurological deficit, or the patient is having bilateral lower limb pain or bilateral lower limb weakness, then we need to go in, put pedicle screws, fix it up, and then decompression. So the management of D7 fracture depends upon the clinical presentation of the patient.
Yeah. There is a question, what is the best treatment for cervical myelopathy? And I would like to answer this question that cervical myelopathy has got the different grades from grade 1 to grade 5, and higher the grade, more the disability. So in the fact, if you look at the grade 1, one can treat that myelopathy conservatively, but as the grade increases to grade 5, then they become the surgical case. So grade 2 onwards, I would say that these are all surgical cases and they should be treated with surgery only. There is a question to Dr. Shivanand, that why do we have patients who had the surgery done but still they have some persistent numbness? So can you just elaborate on that? The persistent numbness after the surgery.
Yes, sir. So because of the preoperative status of the nerve root, there is prolonged compression, there will be demyelination of the fibers. So that demyelination, whatever injury has occurred to the nerve root, it takes some time to recover gradually. So the post-operative periods also, patient will be having this numbness and tingling from 3 to 6 months period, and gradually it will come down as the myelination reoccurs.
Yeah. I think all the questions we have answered. There may be few left. If there are any, you can certainly ask us on our Q&A, and you can go on our website as well. It's been a wonderful session with the help of IT team. I'm thankful to Torrent IT team, my colleagues, my friends, and all the viewers as well to make this webinar successful. Thank you very much. Shreya?
Yes, sir. Thank you so much to all our wonderful speakers for this illustrative discussion. Thank you to all the audience for joining us today on this Thursday evening. The knowledge Carva shall continue, and these recordings are there on YouTube, and we shall also be circulating the link post the webinar with all the people who have registered. And you can subscribe to Stavya channel on YouTube and also their Facebook page for the regular live updates. And Shelcal feels immense gratitude and a big thank you to Dr. Dave, Dr. Ajay, Dr. Devanand, Dr. Shivanand, and Dr. Ravi Ranjan today. It has been such an honor. Thank you so much.
Thank you. Thank you very much. Thank you.
Most welcome, sir.